Good afternoon. I'm Allison Gittens. I'm with the Breast Imaging Division at Cooper University Hospital in Camden, New Jersey, in conjunction with the MD Anderson Center at Cooper Hospital. I have no financial disclosures. And the objectives of my lecture today are to discuss healthcare disparities and how it relates to breast cancer and breast imaging, to discuss different high-risk screening protocols we have, and lastly and briefly, breast imaging in the era of COVID-19. I'd like to thank Dr. Day for her wonderful screening lecture that came just before me. So we know that breast cancer is the most common non-skin cancer diagnosed in the United States and the second leading cause of death in women in the United States. In 2020, there are approximately 325,000 cases of invasive and non-invasive breast cancer predicted, with 42,000 deaths. There are racial and ethnic differences associated with breast cancer, which are important to recognize, as African American women have an earlier age of onset of a diagnosis and a higher incidence of more aggressive breast cancers like triple negative breast cancers. And as Dr. Day explained, that non-Hispanic white women have a higher incidence of breast cancer. However, African American and Hispanic women have higher mortality rates from breast cancer. So the overall death rate decreased approximately 40% in non-Hispanic white women between the time of 1989 and 2017. However, there was only a 26% decrease in death rate in the African American community. And the American Cancer Society reports that non-Hispanic Black women have death rates approximately 39% higher than that of non-Hispanic white women. This chart demonstrates the incidence in US women. This is the Caucasian incidence level, and this is the mortality rate. And you can see that Black women have a higher mortality rate, although a lower incidence of breast cancer. So what is the definition of disparity? The NCI defines it as differences in the incidence, prevalence, mortality, and burden of cancer and related adverse health conditions that exist among specific population groups in the United States. So there are economic, social, and cultural factors that overlap that lead to these disparities, and disparities begin with prevention and continue all the way through survival and mortality. Patient factors associated in breast imaging include lower income levels, patient knowledge and health literacy, lack of health insurance and contact with a primary care physician in the community, patients who live in rural areas of the United States where there is limited access to diagnostic imaging centers, linguistic barriers, cultural beliefs, and the perceived susceptibility or ability to be diagnosed with breast cancer, and then a long-standing medical mistrust in the health system. So with the advent of new screening techniques, there's growing concern that the existing disparity will worsen. There are barriers to screening that still persist. Many of our best screening tools or supplemental screening tools are not offered at all sites, and those tools or screening studies may have out-of-pocket requirements or copays that are difficult for people to pay. There is a delay in diagnosis and treatment, including that of diagnostic breast imaging after an abnormal mammogram. Patients are diagnosed at more advanced stages and have more aggressive tumor biologies. There have been attempts made to close these screening disparities. They include health policy and or financial support to cover screening studies for women in underserved communities, community-based outreach programs to increase awareness and educate women in the community. And then one example of one attempt to close screening disparities is these mobile mammography units to remove geographic barriers. These can go to different places in the community, different work sites, which make it easier for women to get screened. So those patients at high risk may benefit from our supplemental screening tools. Black women are more likely to be diagnosed before the age of 50, which puts them at a disadvantage when certain recommendations are to start screening at age 50. The ACR recommends annual screening to begin at age 40 for women at average risk. If you're at higher risk, you may be asked to start earlier than that. As Dr. Day explained, African American women and those of Ashkenazi Jewish descent should be evaluated for breast cancer risk no later than 30 years old. So I wouldn't be a radiologist if I didn't show some imaging during this lecture. So this is examples of a screening mammography of the right breast, an MLO image. So you can see as we move from left to right, there is increase in breast density. So this is a very fatty breast, scattered, heterogeneously dense, and extremely dense. So as we move towards the extremely dense breast, our sensitivity of being able to detect a breast cancer decreases. The overall sensitivity of mammography is 85%, but it decreases with women in dense breast tissue, anywhere from 47.8 to 64.4%. In addition, women with extremely dense breast tissue have a 4.7-fold increase in developing breast cancer, and it's more likely to be missed due to the overlying breast parenchyma. Women with denser breasts are more likely to have larger tumors at diagnosis and are more often found to be lymph node positive, and interval cancers are more common in women with dense breasts. So new technologies have emerged that improve cancer detection. One is digital breast tomosynthesis, which is widely available in the country. There is a whole breast screening ultrasound or an automated breast ultrasound unit, breast MRI or a fast MRI examination at certain centers. Certain centers have molecular breast imaging, and others have contrast enhanced spectral mammography, which we use often at Cooper University. Breast notification laws have further facilitated the use of these technologies, and currently 38 states in the United States mandate that women receive breast notification laws. Excuse me. So we know that screening mammography reduces mortality in women 40 years of age or older. Tomosynthesis has significantly increased cancer detection rate and decreased false positive recalled rates when compared to digital mammography. MRI is highly sensitive for high-risk screening patients, and supplemental screening with ultrasound can increase cancer detection rate by 1.9 to 4.2%, depending on the population being screened. So the 4.2% is in women at higher risk. So here are some examples of breast imaging that you'll find at dedicated breast imaging centers. The first is a tomosynthesis examination. So this is the regular 2D mammogram, and this is the tomosynthesis image, which really highlights this irregular spiculated mass in the lateral aspect of the patient's breast. More difficult to see here, but on the tomosynthesis imaging, you can see a mass that is spiculated with irregular margins. Here's a left breast mammogram. This was a patient's baseline. Nothing too exciting on the 2D image, but on tomosynthesis, you can see this very spiculated mass in the medial breast. And again, it's able to be visualized much more clearly on the 3D imaging. This is a survey breast ultrasound for dense breast. This woman also has implants, and the survey showed a very irregular hypoechoic mass that went on to biopsy, which was an invasive ductal carcinoma. This is a high-risk MRI. This patient had a previous history of LCIS in the right breast and was found to have a new 3-millimeter mass in the upper inner left breast, which went on to biopsy, which was invasive lobular carcinoma. This is another high-risk patient. She had a normal mammogram 6 months earlier. She went 6 months later for her MRI, and there was the development of a spiculated mass in the upper outer aspect of her right breast. So 9 o'clock, 10 centimeters from the nipple, we were able to find this mass on ultrasound. And here's an image from her biopsy, which was invasive ductal carcinoma. Here are a couple examples of a contrast mammogram. If you don't have these at your institution, this is a young woman from the Camden community who was found to have a breast cancer in the left breast. It was palpable. We had her undergo a contrast mammogram. This was her palpable mass, but we were able to see a satellite lesion just posterior to that, and incidentally, a right breast cancer. And again, here are her conventional images, which are very difficult to see any abnormality, but on contrast mammogram, you can see her palpable mass enhances significantly, as well as the satellite mass and the cancer in the right breast. So moving on, I'm going to speak briefly about imaging in the era of COVID. So quick decisions were made by almost every department, I'm sure, in the country on how to keep patients, staff, everyone safe at the beginning of the pandemic and throughout this rapidly changing course of the pandemic. So we received recommendations from multiple organizations, and then we came up with a collaborative plan at Cooper with our cancer colleague, our cancer center colleagues. We, in our imaging department, postponed all screening mammograms. We reviewed all diagnostic mammograms that were scheduled and determined whether or not we felt it was safe for the patients to have their images postponed until further notice. And we had a discussion with each of those patients. We continued all diagnostic imaging for any new clinical issues, such as a palpable mass or a patient who had a suspected infection, or if the patient was undergoing active cancer treatment and needed follow-up. Image-guided biopsies were also continued as needed. After things seemed to settle down in our particular region, we came up with a plan for a safe reopening. We decided to space out patient examinations. We had appropriate PPE for staff and patients. Everyone was screened prior to coming into the department, as well as at the front door of our office for such thing as fever or any symptoms they may have. So data from the recent COVID era indicate that African American individuals, and to a lesser extent Latino individuals, bear a disproportionate burden of COVID-19 related outcomes. And the pandemic has shown a spotlight on health disparities and created an opportunity to address the causes underlying these inequities. The U.S. Department of Health and Human Services announced a funding plan to deliver important COVID-19 related information to racial and ethnic minority, rural and socially vulnerable communities hardest hit by this pandemic. It's too soon to yet predict the full impact COVID-19 has had on breast imaging and women's health in general. Our main goal in my department is to recapture those patients who are postponed, or have not returned for their screenings or diagnostic studies because they are fearful of coming into our departments. We're trying to educate patients to reduce fear of returning, and we are hopeful to secure funding for our community outreach programs that we work closely with at our hospital. So in conclusion, racial and ethnic disparities play a large role in patient diagnosis and treatment of breast cancer. These disparities have been significantly highlighted during the COVID-19 pandemic. High-risk screening opportunities must be made available for all patients. Breast imagers and centers have a duty to work closely with community outreach organizations. And very importantly, future research must include diverse populations so all women are represented for imaging recommendations. Thank you very much.